We have an agenda today that is a little tight, but I'm going to speak just for a few minutes about what the content will be shaped around. Also, for any of you who were not here yesterday, you can take a break anytime you like to. You can find the bathrooms outside the doors. There's coffee, tea, ice water in the back to your delight. You will have no breaks until lunchtime, all right? And then during lunchtime, we'll have a tiny little agenda for you while you're networking with people at your tables. So be aware that this will be a full day. We will be finished at 4 o'clock today. All right? Makes sense for everybody? Welcome. One of the things that has occurred to many of the people in breastfeeding, and I heard this for not only the summit, for many years as we've dealt with different aspects of the breastfeeding issues, problems, both at a national, state, local, and individual level with patients, is a gap that has been exists as a risk for the continuance of breastfeeding or the sustainability of breastfeeding across the whole population. That is, once a baby has latched on in the hospital, may or may not have been perfectly successful, goes home to a family, hopefully, or a support structure that they can continue to nestle inside that support structure and continue the successful practice of not only nursing their children, but actually becoming mother, child, survivable, wonderful, pair, successful, right? In the middle of all that, in the center of all that, the context of what we're going to be dealing with today, and I just loved all the bios that were sent to me from all the people who are going to be speaking today, but at one point in time in every bio was a commitment towards social resolution of certain problems. Every one of our speakers today has committed, whether they're in the public health domain, the individual support domain, or truly empowered to work on social justice issues. And one of the issues that I considered paramount originally in 1977 when I wrote one of my first papers on the disparity between United States breastfeeding women and Hispanic women in Mexico was that the social network, once a mother had delivered, and even how she delivered, we're not going to talk about that at this conference, the women here in the United States seem to fall back into a black hole of support, and the women in the Latin American culture that I studied were falling forward into the arms of their family. And here's the family, not like we would call a nuclear family. It was the family of a mother or a mother-in-law. It didn't matter whether you were matriarchal or patriarchal in your society structure. Two, they fell into I call it the role of the brothers and sisters of that mother supporting breastfeeding. And then the women of the community, which we'd call community social networking today, rallied around that newborn to make sure that everything was taken care of in that community sense of the family's needs. So if there were little kids running around outside and she had 7 other kids running around, there would be a community of other mothers and networking in the neighborhood that would make sure that those kids were safe, right? Go to school, etc. I come from a large Italian family. My mother and her 2 sisters had 31 kids, all right? When one mother was nursing, another family took over 7 in one family at times, and I can remember being shipped off at a different time for a week or two to another aunt's or another cousin's house or whatever when that baby was around, and coming home at nighttime for dinner, etc. But, you know, how wonderful to have your godparents feed you for a couple days. It was like going to a candy store, right? But that social structure is what I'm going to be talking about today, and how we, as professionals in our organizations, can elicit the beginning, if I can call it that, of a safety net. And that safety net touches all bases of life in the family. All right? It's just not in breastfeeding. For example, the safety net for heart attack prevention may be the control of exercise, right? There are all kinds of safety nets that we can build in social structures. And in those social structures that we're going to talk about today, the one cultural social structure that we don't usually talk about is how we integrate into all common cultures within that cultural dynamic, within that domain, the language, the power, and the ability to form those pathways. They're culturally sensitive and culturally relevant. In fact, I remember one of the articles that I had written in a very, just a rag on health, said that, you know how medicine was in the 70s, you know, you had the journals and then you had rags that we'd get in. And they had quoted me as saying that breastfeeding is culturally determined. And they left out the part that the historical anthropological look at breastfeeding said it was culturally relevant. No, they forgot the first phase, but honestly, that is what we're going to be talking about today. What do we do? How do we represent? How do we start addressing the culture of breastfeeding that is missing in the continuum of care? And I think yesterday we identified that gap once again that exists once they leave the hospital, and then breastfeeding success begins to slide off, all right, without enormous amount of support, and et cetera. The second piece is I'd like to just take about a few minutes to just go through another little cultural piece that we did at Kaiser prior to the electronic health record process change. Back in 1991 and 1992, the health plan I was allowed to have 20 engineers from KPIT, and they were all data modelers and enterprise architects, basically, and that's where I'd come from, an IBM originally. And I was a data modeler, conceptual person in computer programming and development. And I was given 2 years with these 20 individuals who were the rock stars, basically, when they got out of school with their PhDs. And then they came to work at Kaiser. They're just part of the family, you know what I mean? You didn't know that they were rock stars, actually, in what they did. But when we wrote the requirements for the electronic health record, one mode in there represents what I'm going to talk about today, is we took 2 cultural anthropologists, one from Sweden and one, Judith Gregory, from Stanford, and both have their doctorates in social anthropological changes for medicine. They look at how you as doctors or as representatives of a culture of medical service actually do or do not change, and in what velocity, and how you as a culture, and what I'm talking to you today is as a culture of breastfeeding support that's from a paradigm of education in medicine, education in public health, or education in community activism and service, depending on what your focus is. However, you are a culture. And in that culture, we may be here representing one focal point, but there is another part of our culture that represents the disparity or the gap in this other continuum of care. And in the electronic health record, what we decided together, if I can call it that, with the rest of the country, is that in the build that we built for this, we built what's called a community build. And we took that name on purpose so that when we build the software engineering component piece, the community build took our 7 regions basically and took every physician and every workflow, everything that you can imagine, administratively, billing, checking in, all the way down to the care of the patient, rooming in, all the way to the care of whether a mother gets asked whether or not she's going to breastfeed her baby at the very first visit. You know, all those things were integrated into the social support system of change mechanics for the adoption of the electronic health record. So we subsumed another project to be able to put a plant, let's call it plant, a foundation of workflows that could actually generate what we're talking about today in social change, all right? And it was done methodically, analytically, and let me tell you, those of you who are doctors and have MD degrees, you would not like the results when they analyze your practice. You might think you're really good, but let me tell you, it was a humbling experience to have your whole process of how you did your notes, how you thought, how you behaved, how you interacted with the staff, the patient, and if you didn't interact with the mom and the baby when they went home, did not call them up, let me tell you, that was there. All right, it pointed out big things, and it set up the process. About 4 years after we finished that, I also used it to be able to do the baby-friendly piece for Kaiser, of which we'll talk a little bit about that today. In the baby-friendly piece with Northern and Southern California and the rest of our institutions that have hospitals, we have been a force to reckon with on the UNICEF side to be able to adopt processes within hospitals that can support what we have talked about and form that internal culture, not perfect, not the best yet, but it's an internal culture that we continue to grow. So with that, I'm going to leave our speakers to really fill in some of these gaps today.